Ladies and gentlemen, thank you for standing by, and welcome to the Ask Dr. Susan Wehry conference call. During the presentation, all participants will be in a listen-only mode. Afterwards, we will conduct a question-and-answer session. At that time, if you have a question, we ask you to please press the 1 followed by the 4 on your telephone keypad. Should you need to speak to an operator at any time during the conference, you may do so by pressing star 0. I would like to remind you today's call is being recorded Thursday, September 16th, 2010. And now I have the pleasure to introduce Ms. Melissa Lake Spencer. Please go ahead, ma'am.
Thank you all so much for joining us this call today. The center is very pleased to have Dr. Susan Wehry with us for a call. And this call is a little bit different than the other calls that we do in that we're going to let you ask questions of the speaker. So jot down your questions as you can be prepared to jump in and ask questions as we go. Again, we'll talk later about how to ask a question, what the procedure will be. And I'd like to turn the call over to Sarah Hunt to introduce Dr. Wehry.
Thank you, Melissa. It's my great pleasure to introduce Susan Wehry, and I really am sincere in saying that, Susan. Some of you know her, have heard her. She is a wonderful friend of Ombudsman, but most importantly, an advocate for a lot of the people that we know and serve and work with every day. Susan is a board-certified geriatric psychiatrist. She has had a number of jobs, including being a former Deputy Commissioner of Health. She's a consultant to the Vermont Department of Disabilities, Aging, and Independent Living. She has been working with many states on several different initiatives. She has been working with the Ombudsman program over the years, has developed a curriculum that's really excellent for the New York Ombudsman program on understanding and working with individuals with mental health conditions. That curriculum, thanks to the New York program, has been shared and is now on the NORC website. The PowerPoints, the teaching notes, the exercises, and the outlines for the various modules. It's very good for using in Ombudsman training as well as possibly even with some consumer groups or with facility staff. Susan really is an advocate and has been very involved in the culture change and pioneer movement as well. The reason we're having this call is that a year ago it's been almost exactly a year, we had Susan on another call giving information about tips in working with individuals with mental health conditions. I think one of the reasons she resonates so well with Ombudsman is that she focuses a lot on the individual and really listening and getting to know the person and not letting a label or a diagnosis or behavior stop the flow of conversation and understanding what that person is all about. And we continue to get a lot of calls at the Resource Center and a lot of questions about what's the best approach because situations are very complex and there are a lot of emotions involved. So we recently developed a mental health quick reference guide that you will receive after this call and will be posted on the NORC website that lists some annotated resources and distills a lot of the kernels of wisdom that Susan has shared with us over the years. So we hope that's a handy-dandy reference tool for you. But bottom line is, last year we didn't have a lot of time for people to ask Susan questions, and we felt like the application piece of the principles she was teaching and the suggestions she was making about where to go for resources and how to build those and rally those in your community still left us hanging a little bit with, so how does that really apply to the person I'm working with in this particular facility? And Susan was gracious enough to agree to do part 2, which is today's call, which will be primarily based on you asking Susan your questions. This is a wonderful opportunity for you to take advantage of an expert in the field who really gets it with long-term care. So it's really a dialogue with Dr. Wary today. And to kind of get the ball rolling, what I would like to do is pose a question that we get quite frequently from a number of ombudsmen. And some of the situations and variables may change a little bit, but in a nutshell, I'd like to pose it to Susan and let you respond, and then after that, Melissa will take over and facilitate the traffic flow as all of you ask your questions of Susan. So, Susan, the question that we get a lot is how to deal with the situation where a resident in a facility has a mental health diagnosis, previously has been on medication that kind of makes the person, I guess, easier to live with, and the person decides, I've had it, no more medication, I don't want to take them anymore. So then kind of an uproar ensues. The family's upset and distressed and doesn't understand why the facility can't just make the resident take their meds. And the facility, in fact, would very much like to find some way to disguise the meds and get the person back on the medication. And sometimes it's very difficult for the ombudsman to help everyone remember that the resident, the individual, still has decision-making authority over their lives, and to try to shift the nature of the conversation and the dialogue and bring in appropriate people to really look at things from the resident perspective. Because a lot of times these end in involuntary transfer and discharge or discharge to a psychiatric facility, and then there's no bed available for the person to come back, and on and on and on. So, Susan, can you give us some guidance on what to do in those situations?
I'd be happy to. And first of all, I want to thank you for your kind opening remarks and say hello to everybody who's out there. When this call started, last we heard, we had on our way to about 50 people of the 90 or so that we expect. So thank you all for being here. It's a little hard not to be able to see you. It's always such a pleasure to work with ombudsmen, as Sarah has. I've been doing for a lot of years now. And I think one reason it's always such an honor and privilege to be asked to talk with you, to put our heads together on these various problems, is because I really know of no other group advocating for people with mental health conditions, people who are residents, people who need someone to provide a voice for them. I don't know anybody who is as optimistic and can do as ombudsman. So it's my privilege to be here, and I thank you. The issue of medications for people with mental health conditions is a very complicated one, because on the one hand, you have the treatment system that recognizes that in general, if a person does suffer from a severe mental illness, such as, let's say, schizophrenia or bipolar disorder with psychosis, the evidence is pretty good that two things help: housing and medication. From an evidence-based standpoint, those are the two things that help people with major mental illness. And so the wish to have people on medications and for them to have a good place to live is understandable. The problem is, and I think this is what ombudsman can be very helpful with, is that only the person taking the pill knows what a high price they pay for being on medications. The old medications that we used to use, those of you who go back as far as I do, things like Mellaril, Thorazine, Stelazine, and Prolixin, either had people shuffling, drooling, and sleeping, or had them with a lot of abnormal motor movements that not only caused them to appear different to others, but felt different. And so medications, while they stop voices and while they help with delusions, that's usually true, and may help organize thinking, they come at quite a price, and I think that people in the healthcare field forget this sometimes. Then as newer medications came along and we got rid of some of the worst of the side effects, we've added a whole new set of side effects, and they include things like 70-pound weight gains within the first 6 months of being on a medication. Include things like sedation. Include things like not being able to think as clearly from the resident's point of view, even if being able to have more organized thoughts. So, what to do? My thought when a person who has been taking medications suddenly, or not, perhaps not so suddenly, announces, I'm not going to anymore, is to try to take it back to the why now question. The side effects have always been there. Now a person says, I want to stop. I have a few hunches about what sometimes triggers that. One, if a facility or caretakers begin to overemphasize medications as the most meaningful treatment for the person, they will oftentimes express their displeasure by saying, I'm not going to take it anymore. I'm a person here. I'm not just about my medications. So let's say, here's what can happen. The person is going along, taking their medicine, not hearing voices, maybe not liking the side effects, but kind of going along. And then they have a bad day, like you or I have a bad day. And somebody immediately says to them, instead of, how are you doing, did you take your medicines today? The person feels dismissed, invalidated, and they say, if you only see me as a pill taker, then we're changing this equation. Now, I'm not saying this happens consciously. I just try to have some guesses about why might somebody suddenly stop. So that's number one. The why now. Has the conversation become too much about medications? The second reason that people stop taking their medications seemingly abruptly is because they have lost control over some other aspect of their life. Look for things like, did they just get a new roommate? Did they just have to change their room? Would they change where they were going to sit? Did somebody who used to visit quit visiting them? Some other dimension of life in which they lost some control can become a trigger for suddenly stopping taking medication. So the issue really isn't in that case about the side effects. The issue in that case is really about reclaiming control. And if you think about a lot of long-term care facilities, not all of them, but sometimes the only thing you can control is taking or not taking your pills, eating or not eating, going to the bathroom or not. And it gets pretty primitive in some places where they exert a lot of control. So I look at why now and two guesses. Loss of control over something or an alteration in the quality of the relationship with the caregiver. The third reason that people stop taking medications or don't want to go on them in the first place is because the side effects are lousy. And they are. And that needs to be acknowledged and honored and validated. And just like people who have to take medications for high blood pressure or for any number of conditions might not like the side effects, somebody needs to have a reasonable conversation with them that says, I get it. I wouldn't want to take this medicine either, but your choices here are to really be overwhelmed by these voices and not have side effects, or maybe have some side effects and maybe we can dampen the voices a little bit. So it becomes a matter of trying to get that right balance between side effects and the right dose. That requires having a relationship and a conversation. So I think in the situation where now, as Sarah describes her question, what do you do when the person has stopped and there is an expectation that the person's going to go downhill? People with major mental illness like schizophrenia, you stop your pill today, you're not going to become acutely psychotic tomorrow. But that's kind of the anxiety that's out there, that something bad is going to happen, and it becomes kind of a self-fulfilling prophecy. So kind of in anticipation of that, everybody gets sort of anxious. The family says, can't you just slip it into their orange juice? Not only is that illegal, it leads to mistrust in relationships, and that's a bad idea. And I think where there's pressure from the family or from somebody else to kind of trick the person or make them take it or use some reinforcement, the role of the ombudsman, I think, the way you can be most helpful is to ask for a sit-down. First, meet with the resident and say, help me understand this. You used to take this medicine, so I'm guessing maybe you used to think it helped, and now you don't want to take it anymore. Help me understand that. They may or may not be able to tell you. If they tell you it's because they're now having side effects, it could be because They've just had another medicine added that's making side effects of this one worse. So you can say, let's talk to your doctor about that. It could be because the person has an intervening cold or infection or whatever, but something that's making them feel worse. So in other words, your first step, sit down, and not just the dialogue about you have the right not to take them. Of course they do. That's the given. Our job is to say, how come you're exercising that right in this way now? Person may say, because they made me mad and I'm just getting back at them. Great, now we can go somewhere. Wonder if there's another way to get back at them. Why did they make you mad? What happened? So you begin a dialogue where you understand where the resident's coming from, not just their right to refuse, because that's important, but it's limiting. So why are they refusing? Then you ask the resident if he or she would like to have a sit-down to help the staff understand. And, if facilities operated with more flexible, individualized care planning, this would be the place to do it. You'd have a sit-down. The family member that's pushing for meds could come in, and the facility staff and you and the resident might sit down together and say, why do these drugs seem so important, and be able to see if they fit into the care plan. I think at such a meeting, the best voice for the ombudsman to have is to really try to teach people or help people understand that there are really good reasons that people don't want to take their medications. Just as there are good reasons to take them, there are good reasons not to take them. And the resident's capacity to make an informed choice has to be honored. And they need to be given the dignity of all the facts so they can participate in making that decision. So I think, that's kind of the way I approach these, and it comes up all the time. With respect to the person saying, we do all of that, they still don't want to take their medication, and the facility starts, worrying that they're going to act up and have to be discharged, I think your task then is to, before that happens, is to ask the facility to take a step back and really ask themselves, what are we afraid of? What do we think is going to happen? Are there any earlier warning signs where we don't have to get into a discharge mode, where we don't have to get into a hospitalization mode? A lot of people go off their meds and don't decompensate for 2 years. Some people go off their medications and decompensate in 1 month, and some people, even while on their medication, decompensate anyway. So that perspective facilities need to have, that there's nothing magic about these pills. Decompensation doesn't happen overnight. We can look for early warning signs, and then that's a conversation they can also have with the resident. Okay, I get it. These meds, you don't want to take it. But let's keep an eye on things together. If you start feeling more anxious, and that's an early warning sign of getting worse, maybe you'd consider going back on half your dose, or maybe that's a reason to get the doctor on. I hope what you're hearing in all of this is that no decision is final, all decisions are to be respected, and all decisions are to be explored and not just taken at face value. It's a process and requires an ongoing relationship. Does that help?
Yes, I think it does a lot. And if not, we'll have the callers ask for more specifics. But thank you.
Yes, you're welcome. Thank you. Good question.
Okay, operator, we're ready for questions now.
Thank you. Ladies and gentlemen, if you would like to register a question, please press the 1 followed by the 4. If your question has been answered and you would like to withdraw your registration, please press 1, 3. If you are using a speakerphone, we ask you to please pick up the handset before placing your request. One moment, please, for the first question. Ladies and gentlemen, as a reminder, if you have a question, please press the 1 followed by the 4. And the first question is coming from the line of Sandra Everhart. Please proceed.
Good afternoon, Dr. Wary.
Hi, Sandra.
Hi. My question is, what can an ombudsman do to help or support a resident with the behavioral health condition of hoarding after a facility staff group have gone in and deep cleaned her nursing home room without her knowledge and in her absence. The resident is currently depressed, grieving, and desperate to leave the facility AMA.
Wow, thanks, Sandra. That's a question with a lot of layers to it. May I ask you to stay on the line? Well, I guess you're on the line anyway. To ask you a couple of things about that. Do you know, for example, how long she has been there?
4 years.
About 4 years? Okay, thanks. And do you know if she has any relationships there?
Yes, she does.
Okay. And actually, I mean to imply positive relationships. Okay. And prior to this breach in trust and a lot of other things I'll talk about, did she like it there?
Yes, she did. One of the things that they cleaned out was she had a pile of magazines that her sister had given her, and her sister died a few months ago.
My God. And I gather that these things really are irretrievable.
They're already gone.
They're already gone. Yeah, this is a tragic misunderstanding, I think, of the whole problem of hoarding. And this is going to be hard to heal. One of the problems, of course, is that the desired resolution, that is, that she gets her things back, is not achievable. And so there are several levels on which we could look at this problem. Let me first take up, though, just the issue of hoarding, because I want to say something about hoarding, and that is, if you haven't heard about the book called Stuff, S-T-U-F-F, subtitled Compulsive Hoarding and the Meaning of Things, I would really like to encourage you to take a look at it. It is one of the most humanistic portrayals of the problem of hoarding that I've ever read. It was written by a guy named Randy Frost and his colleague Gail Piketty, I think is how she says her name. And they really have become sort of the darlings of the hoarding task force everywhere, and with good reason. They're thoughtful, scientific, compassionate, and really bring to the condition of hoarding a whole level of understanding. And it's not that they de-pathologize it, it's that they give it a context, a meaning, and a way to help people with it. So before I forget, I just want to recommend that book to your attention. So I'll set that aside for a moment. What strikes me about this problem that you've brought up is that you have a situation in which I suspect the facility felt, quote, they had no choice but to go in and deep clean her room. And I suspect that they felt that they, quote, had to because of either substantiated or non-substantiated, exaggerated or not exaggerated worries about the secondary problems that clutter can bring. Things like, insects coming in, getting dirty, or so much clutter you can't get around it and then being a fall risk. It is not at all uncommon when people have hoarding conditions that those around them develop over time their own anxiety and their own need to act. That sort of, we've got to do something. And so what happened is not uncommon. Whatever level of mess she had by their perception, it was a mess. It posed some kind of hazard that they thought justified absolutely non-justifiable actions, which was while she was gone, they took care of it. This happens in the community. I have to admit, it's the first time I've heard about it happening in a nursing home, though I bet it happens all the time, and I just have never heard about it. So, there are two problems here. One is, of course, the hoarding, and then the second is the facility did something, in my view, which is wrong. Wrong in the sense of completely underappreciating the meaning of her stuff to her. Even without the poignant feature of magazines having belonged to her now and recently deceased sister, I can tell you that if this woman really does have the behavioral health condition of hoarding, that in fact many of her things will have tremendous meaning to her, because there is this phenomenon for well over half of people who hoard of not being able to throw things out because of its potential use, but more importantly because of its meaning to them and a sense of ownership. So I think the facility was wrong. They're wrong if we take it from a Maslow sense and say, what are basic human needs? Well, a big one is a sense of safety and security. And safety and security means this is my room, this is my stuff, I keep it where I want, I'm entitled to my privacy. It's wrong, possibly, violation in a legal sense because of the violation of privacy. It's wrong in the human sense of rupturing a relationship in which if you have lived with people for 4 years, you trust them, you believe they're taking care of you, you have relationships, you like it there, you go away and you come back and your space has been violated, is a tremendous blow on many levels. I am not the least bit surprised that she is depressed and grieving and wants to leave against medical advice. Part of what to do, I think, is really depends on what she wants ultimately. Ultimately, if we can help her through the depression and grieving process, would she like to call it home again? Has the rupture been too great? These are things that's really kind of hard to know without talking with her. But a starting point, I think, for this conversation with her and with the facility is that, in my opinion, they owe her an apology at a minimum, which they may or may not have already offered. And an apology without quibbling, an apology without caveats, an apology of, well, we're sorry you're so upset, but we had to do it because there were cockroaches in there. I'm sorry we had to do it, but we were worried about you falling. There are no buts here. We're sorry. We made a mistake. We were wrong. Because in every situation in which the city, the county, the family, the well-intentioned neighbor, the loving spouse goes in and clears out a hoarder's space without their knowledge when they're gone, it is always very disruptive and debilitating to the so-called person who hoards. So her reaction is typical. It's understandable. It's, well, as I say, not uncommon. And like all breaches, it can be healed if she wishes to and if they are willing to. I think it starts with an apology, a recognition that they failed to see the whole picture. Now, how can you help them get there? I think one thing you can do is have them read the book Stuff. A second thing you can do is to send them to to a website, and I'll have to get you the link. I forget what it is, but I think it might be called OC Foundation. It's the International OCD Foundation, and it's where Drs. Frost and Spicchetti actually publish all of their stuff. I'm pretty sure it's www.OCF or ocfoundation.org/hoarding. And so I think what I might do in this situation is that, again, if this resident has the cognitive capacity for a conversation in which the ombudsman can sit down with her and acknowledge that this ought not have happened, that her reaction is reasonable and understandable, that perhaps it may be too soon in the grieving process, but perhaps it could be used as an opportunity for the facility to learn something about hoarding. And then that's kind of where you come in with being able to provide them resources so that they can learn about hoarding. And, you know, I think asking somebody who's been hurt to be the teacher, if you will, or say, well, I hope they learn from your experience, is something that has to be done at the right time, because otherwise it feels insensitive. But if she wants to stay there, and if she has enough relationships to make that meaningful, then I think this is the path to it. Finally, I think you should know that there are, I'm more familiar with this, as I say, for community situations than I am in nursing homes, but I think there are about, I don't know, maybe we're up to 50, but I think about 35 nationwide hoarding task forces. They started, I think, maybe in the 80s. Massachusetts has a particularly strong one, so you could Google Massachusetts Task Force on Hoarding, and you could see if there's a hoarding task force in your community. They would be a great resource for coming into the facility to teach them about hoarding and to help them see why what they did, even if their behavior is also understandable, it was wrong. And that the wrongness of it doesn't stop with just being critical. The wrongness is, let's not ever make that mistake again. And here's how we can deal with it instead. So I hope that the breach can heal, because 4 years of relationships is a long time. On the other hand, if this facility doesn't have a good track record with conflict resolution or learning from its mistakes or taking the high road and being willing to say, I'm sorry, if they're not up to doing their side of, healing this breach, then perhaps helping her find another place to live would also have merit, and that could be another outcome. If she has a serious hoarding condition, then I think any place she goes should have a training on hoarding before she gets there.
Okay, great. Thank you for that question, Sandra. Do we have another question ready?
Yes, indeed. And we do have a question coming from the line of Elizabeth Yeh. Please proceed with your question.
Hello. What's the definition for decomposition?
The definition for,
Composition.
Decompensation.
Mm-hmm.
That's a great question. I can tell you generally, it just means that the person's, quote, falling apart. It comes in part from the meaning, not from the meaning, but let's see how to explain this. When we have limitations, any of us, about anything, whether we have a little forgetfulness, a little memory problem, or a little anxiety, or a little sadness, we compensate by using what we typically think of as our skills, our coping strategies, our defense mechanisms, and so forth. Those are all sort of mental health terms for saying compensating is how we get by in the face of stress, negative emotions, or mental health problems. So when somebody decompensates, it means that their strategies for coping, their strategies for getting by, are no longer working. Now, let me ask you, in what context or what situation has that word been used recently in your experience?
Psychotropic medications.
As a reason to make them take them, or?
Well, getting them off, since they've been on it for quite a while, and then they decided to take them off.
Okay. And then somebody says they decompensate.
Right. And some of them go very fast, and some of them go very slow.
Okay. So, yes, so decompensation means fall apart, would be another way to put it then. And yes, you'll hear this word used commonly, just in the situation you described. If he goes off his psychotropics, he will decompensate, i.e., he will fall apart. And as you say, sometimes it happens fast, and as I also said a moment ago, sometimes it happens quickly, and sometimes it takes a longer time. And sometimes, I should add, it doesn't happen at all. But decompensate just means fall apart. In the case of people who have been on medication, let's say, and the medication keeps them from hearing voices, they go off their medication, those voices may or may not come back. If they do come back, they may or may not come back in its full force. And thirdly, they may be less of a bother than they used to be. These factors are so individualized. And that's why, I like to remind people to really look at the individual. Some of you may recall I told a story in one of our trainings before about a person that I used to work with. This was very early on in my career when I worked with young adults with schizophrenia in particular. And I had patients oftentimes tell me that they didn't actually mind hearing voices at all until the voices got mean. So a person with schizophrenia might hear a voice every morning when they get up saying, go to work, watch the bus, there's the red sign, that means turn here, and not be bothered by it at all. And then, when they could tell they were beginning to, quote, decompensate or get sick, they would wake up in the morning and they'd say, you can't go to work, you're stupid. You can't go to work, you're stupid. Don't get on the bus, the bus is going to crash. And the content and the tone and the voice would change. And they would say, I'm beginning to decompensate. So having a symptom or not having a symptom isn't as important as how much that symptom gets in the way of the person's life. But anyway, I'm going on and on, Elizabeth, because you gave me an opportunity to talk again. But to a simple question of what's decompensate, that's what it is.
Great. Thank you so much for your question,
You're welcome.
Elizabeth.
Thank you. And the following question, coming from the line of Linda Pickett. Please proceed with the question.
Good afternoon. I guess you can hear me. Good afternoon. I'm Linda Pickett. I had a question with regard specifically to mental personal care home residents. They usually have a lot less supervision.
Mm-hmm.
They usually have a lot less supervision, a little more freedom. And my concern is sort of balancing their need for autonomy versus sort of safety in the environment, specifically when it has to deal with lack of compliance with regard to maybe substance abuse and alcoholism, things that really take them to another level, and how you sort of balance and support them with regard to their decisions to do those things without being an enabler.
Well, when you and I figure that out, we should write a book about it.
Okay.
This really is one of the most vexing problems in long-term care. In personal care homes, people living in their own homes, people living in group homes, where, as you say, they actually have the opportunity to exercise autonomy. They actually have the opportunity to make decisions, including decisions that might put them in harm's way, even without major mental illness. This is the dilemma for the person with just a simple substance abuse disorder. The person who, by virtue of having a drug addiction, cannot seem to not do something that puts them in harm's way, risks their placements, risks their jobs, risks their relationships with other people. It really is a very vexing problem. So, the way I try to work with individuals, I really don't have a good global answer for this, because this is one where, I guess every time it comes down to individualized care, but I think for the situation you described, how do I help a person balance their autonomy and their safety, support their decision-making without enabling them, comes down to placing that seeming like balancing act into a larger context. What do I mean by that? Let's say, for example, that the person who let me think of a good example here. Let's say that the person who wants to drink frames that conversation as, it's my right to drink, I have the freedom to drink, I want to drink, or smoke marijuana, or snort cocaine, or whatever it is, that maybe the conversation, rather than being about your right or non-right to do that, is to try to broaden the conversation to, okay, well, what are the consequences of that? I mean, one of the things about autonomy, I think, that we often leave off the table is the notion that the right to self-determination, the right to choose, includes within it the right and the responsibility to be responsible for one's actions. And so I think in part it becomes a conversation about, okay, of course you can drink. Of course you can do that. That's not the issue here. The issue here is, what's going to happen if you do? What are the risks? What are the consequences of your decision? So that I take the balancing act or the discussion about it's my right kind of off the table. I think of this as a tug of war. I think of this as two people pulling, I have the right, but I have to keep you safe. As being in one of that game of tug of war where two people are pulling and you try to pull people to the other side. Well, the best way to win that game is to drop your rope, because the other side always falls down. And the notion here is that it's not about autonomy or safety. It's about autonomy is the given. Of course you have the right to choose. My job is to help people make choices that actually further their gains in the big picture. Yes, you can drink. Yes, you don't care if you get thrown out of here, but you were wanting to go back to school. Yes, you can drink. Yes, you can get thrown out of here. Yes, you don't care about going back to school. You were wanting a job. You were wanting a car. You want spending money. You don't want to go back to the hospital. You don't want to steal. You don't want to remind people that they actually have better reasons than a fight about their autonomy to make decisions. I think that's how you work with people. Now, how you work with facilities, I think, to create environments in which people want to make better choices is another way to approach this, kind of taking an environmental approach in personal care homes. When I look at personal care homes, in fact, I'm doing a really heartbreaking and sobering consultation in a facility right now in good old Vermont, where, believe it or not, they're actually using cigarettes as positive reinforcement for a lady with end-stage COPD. Okay? It's like appalling, absolutely appalling. And yet, when I talk to her and ask her what makes life meaningful and good, she says smoking. So they're kind of in this one together. And so I talk with her and I say, okay, so you really like to smoke. What else do you like to do? And she says, well, there's nothing else I can do. Well, if you could do it here, what would you do? And I bump up against the reality of personal care homes. It's the same reality in nursing homes. People are really bored. And when people are really bored and there's tremendous idleness, you get people engaging more in, say, substance abuse disorders or petty mischief or even, kind of criminal activity. So one approach is from the resident's point of view, shifting the conversation to what's important to you in life. And when the answer is the thing that you wish it weren't, like, I don't, cigarettes, that's important. Okay, great. What else? Then you look at the environment and ask, is this a place I would want to live? If I lived here, how would I spend my day? There is nothing to do. And then you begin to work with the facility to say, we're not creating environments in which people have healthy choices to make, and really go to work on the boredom issue, finding meaningful activities over the course of the day, whether that's odd jobs, whether that's finding the local mental health resource. One thing I will say for Good Old Vermont is that we do have pretty good recovery resources. We do have pretty good peer support groups, so that if we do have people in personal care homes where they don't have a lot to offer, there might be a clubhouse in the neighborhood or not too far away. Then your job becomes helping the person. In other words, I guess what I'm trying to say is they've already demonstrated a capacity to have less supervision. They can use more freedom, or they're in a situation where they're entitled to more freedom. But particularly for people who have been institutionalized for a long time, they may not know how to use that freedom. So our job in part, and I don't think this is enabling in a negative sense, I think it's helping a person who only knows how to use their freedom to get drugs, to show them that they can use their freedom to do other things. And so it might be a matter of, I'm just kind of thinking out loud as I'm going here, but it might be a matter of finding if there are people who can, like OTs used to do a lot of this, do leisure skill training, kind of how to have fun in your life, and would be the other way that I think about it. Does that help, Linda? Did I address the question?
Yes, you did. Thanks a lot. You gave a lot of good strategies and things to think about. I am in Philadelphia, and it is just a major problem for us.
Yeah.
Thank you.
Yeah. Yeah. Thanks for your question.
Mm-hmm.
Thank you. The following question coming from the line of Alice Head. Please proceed with the question.
Hi, this is actually Lisa Green calling on behalf of Alice Head. How's everybody doing?
Okay. So, Alice, I said hello. This is Susan.
I will. My question is, obviously the topic of mental health is a very sensitive topic to people. How should an ombudsman address the issue of a psychiatric evaluation with a resident that has refused one in the past?
Okay. I think ways that I think as a general rule, the way to approach any difficult conversation is to think first about what's in it for the resident. That we have a tendency, I think, because mental health conditions are seen as being more sensitive, to first anticipate that they're not going to want one, and we have some evidence because they've refused one before. So first we have to ask our state, and the facility does, why do I want one so badly? Why do I think that this will increase the quality of life for this resident? Is this just about the fact that they have the label of a mental illness, or in fact, are there ways in which the person is suffering But I actually think if we could get a psychiatric evaluation, it would help ease their suffering. So the first task, I think, is to be really clear in your own mind, about why the psychiatric evaluation is being sought. The second thing is, of what value is it to the resident, or of what value might they see it as being to them, separate from how a healthcare or professional might see the value. When you can answer those things, then I think it becomes a matter like any difficult intervention. Then it's a matter of approaching the resident saying, we notice that you are fill in the blank, or you don't seem as happy here as you used to be. I'd like somebody to see you about your depression. I think you might be depressed. Do you feel depressed? Always, saying what you see, why you're worried, and then asking if the person shares your point of view. We have gotten ourselves into such a mess with this mind-body split, and treating the brain is so different, and kind of tentative about it. I'm pretty straightforward. I'm not embarrassed to ask about it. I don't think that it's belittling. And I have to tell you, in my now 30 years as a psychiatrist, I've never had a person turn me away, even though I've had many people at the outset say, why am I seeing a shrink? I'm not crazy. Who sent you? And so forth. I've done a lot of home visits with a lot of really suspicious, mistrustful people who really didn't want me to come, and I respected that, but I was there for some reason. And I have to tell you, I have always been successful when I acknowledge up front, like, why I'm there, and that I get it that the other person may prefer that I'm not. But given that I am, is there any way I can be of help? So, a lot of times, this just happened to me yesterday. I went to see somebody, and they said, don't tell him you're a psychiatrist. He won't talk to you if you do. And the staff person of this nursing home says, hi, this is a friend of mine I asked to come see you. Now, how disrespectful is that? And this was a resident who has a known mental health condition, who is thought to be refusing psychiatric evaluations that people thought it was sensitive. And he looks at me and says, so who are you really? People know. And I said, who I am really is a geriatric psychiatrist. And I hope you'll talk to me anyway. And we went on and had a conversation. So let me bullet this. Somebody has refused a psychiatric evaluation before, and there's good reason to think that it would have been helpful. Don't assume that it's just because they lack insight because they have a mental illness. Assume that people with mental illness, like people without mental illness, would prefer to feel good than bad. Assume that people with mental illness, just as people without mental illness, will accept help if it is offered in a way that doesn't threaten their autonomy. They will accept help if it doesn't threaten their kind of sense of self. They will accept help if it's respectful and coming from a specific person and not a purpose, and not just coming because they have a label. The other strategy, I think, so approach it pretty straightforwardly. The other thing I would say is that for those of you who do have good geriatric mental health resources in your communities, I would actually ask that person, like this happens here a lot. People say they don't want a psych eval, and somebody will say, well, I go see them anyway. And I will go see them, and I will say, I know that that you did not want to have an evaluation, and I mean no disrespect, but people are really worried about you here. Will you just talk to me? And sometimes, for those of us who do this and kind of communicate by our body language and everything else, but we don't think there's anything about it, people will sometimes accept it. So if the facility is tentative and like is afraid to approach somebody, that will be communicated in their body language. So get somebody to do the approach who can communicate by every like aspect of who they are that this is a good thing and not something to worry about.
Thank you. Yes.
Okay. Thanks, Lisa.
Thank you.
Thank you. The following question comes from the line of Erin Nelson. Please proceed with the question.
Hi, Dr. Weary.
Hello, Erin.
My question is this. A resident who lives in an assisted living facility, overall for him living there, things are going well. However, he does have a mental health diagnosis.
Okay.
I believe of paranoid schizophrenia, but I'm not positive of his diagnosis.
Okay.
The problem is that he says randomly very threatening statements to other residents.
Okay.
There's no history of violence or any type of harm that he's, caused others in the past. He just has these verbal kind of outbursts.
Mm-hmm.
The residents, of course, that are subjected to them get very upset and get fearful and want to know why the facility doesn't, kick him out.
Mm-hmm.
The facility tries to reassure the residents that it's just talk and that he's not going to do harm, but they also are real hesitant because they don't want to violate his rights about disclosing his mental health illness or mental health diagnosis.
Mm-hmm.
I guess the question is, are there any tips or ideas for either conflict resolution or managing relationships with folks in long-term care settings when you have this kind of dynamic?
Great question. In fact, they've all been great questions. I was so afraid before we started that we wouldn't have any, and now we only have good ones. That's excellent. I think that there are actually a lot of tips on this one, Erin, and I think you framed the question exactly right. How do you do conflict resolution in group living situations where people probably didn't know each other before and have to figure out how to get along? And given that they're probably living in a group living situation because they have problems in living. So it's a kind of tall order, but I think it's actually pretty doable. One question for you first, though, about this particular situation. What is the mechanism at the place that you mentioned in assisted living for conflict resolution about other issues? Do they have a resident council or any other kind of resident-driven decision-making body?
Yes, they do have a resident council there.
Okay, and what kinds of issues do they take up there typically?
More, not really interrelational ones, but more things they want to see, different at the facility, or activities they want to do, or comments about the food, that kind of thing. But they don't typically address interrelationship type issues.
Okay. So if there are interpersonal conflicts in other domains, not related to somebody having or not having an illness, does staff have any training in stepping in the acute situation rather than, say, the more ongoing one?
I think maybe just basic training in terms of, I know that they have had off and on maybe two residents who are having a disagreement, and staff will do what they can to intervene and help them work through it. In this particular case, it's more of a challenge because how do you work through something that's probably not going to stop? And get the residents to feel still safe in that environment.
Okay. Well, let me challenge your first assumption that it's probably not going to stop. Let's remember, and this I think is probably going to be in the handbook that I think Melissa mentioned at the beginning, or maybe Sarah, about my number one tenet, which is all behavior is communication. If a resident, this person that you mentioned who has paranoid schizophrenia, randomly is making threats at people, then that seemingly random moment has meaning. In other words, it's one kind of behavior if somebody sits outside their door and nonstop, all day, makes threats. Anybody there, not there, whatever. That's a different behavior than somebody who only makes threats when other men walk by, or somebody only makes threats when women walk by, or only makes threats if they're smoking and they don't want the person taking their cigarettes, or whatever it is. Sometimes things seem more random than they are. In general, when a person with or without paranoid schizophrenia does something aggressive and threatening to other people who did not provoke them, it generally means, quite simply, keep your distance. Any of you who live in large urban areas and have ever ridden a subway where there are a lot of people who seem to have a mental illness, who may or may not be homeless, you will notice that they are often the only people on the subways with a seat and with a lot of space around them. They behave in ways oftentimes that make other people uncomfortable for the precise purpose of clearing the space around them. A person with paranoid schizophrenia who is randomly making threats, it's like kind of like a barking dog. It's stay away. And without the facility having to reveal anything about a mental illness, the question is, how do you communicate to other people who haven't picked up on this themselves that there's a certain difference in this person's personal space and personal safety needs for them not to be threatening? But that's really what we always have to go back to. What does his behavior mean? It appears random, but I would encourage the facility to pay a little closer attention. To see, in fact, is it when the place is noisier? Is it when meals are late? Is it when meals are early? Is there anything at all we can get a handle on so as to make the environment not trigger the behavior that says, keep your distance? Now, this is different than somebody who, has a history of aggression where the first verbal assault is followed quickly by a fist. You'd think about it differently. But from what you describe in this person, see, I guess here's what I'm trying to say if I'm not being clear. It sounds as though people are saying, or there's maybe a thought or a theory that he's randomly aggressive because he has paranoid schizophrenia. And because it's a symptom, it will never go away. And we can't tell other people about it because of confidentiality, so we're kind of stuck. What I'm saying is, yes, he has paranoid schizophrenia, and yes, that makes it harder for him to simply ask people to keep their distance. But the behavior itself is a communication of something, kind of just as if he didn't have schizophrenia. He has schizophrenia, so he takes this route, but he's still trying to say something. So I would encourage them to not dismiss it just as a symptom, to accept that his having paranoid schizophrenia may render him more fearful as kind of a baseline, and so more likely to want more space. His having schizophrenia may make it harder for him to have the usual kind of social interaction of keeping the distance. So their job is going to be to help him manage, I think, that distance from others. I guess the only other thing I'd say about it is, does this person have a case manager or a community support worker or anybody else in his life who could take him out of the assisted living facility to kind of ease the tension for everybody from time to time? Just get a cup of coffee or whatever. Is that resource available to him?
They're actually looking into what resources might be available. So far, he's not very open to it, but I don't know how they've presented it. So
yes, okay. Yeah, I think, I just can't say enough about the importance. I think one reason that you guys are so good at your jobs is that from the get-go, you're about presenting the resident's point of view. And that is conveyed from the first time you meet them. So oftentimes, I think people with mental illness have had the experience from the mental health system of having people come in with an agenda of their own. I'm going to make a relationship so I can get you to take your meds, or I'm going to come see you so I can manage your money better. And it's not that I think people, I'm in that system. It's not that I think that we're not as compassionate or thoughtful, but I think we go about our job wrong. However, if somebody is willing to do just what you do, if you can help them understand that, which is I'd like to come in and get to know you. That's it. To see if I can be of any help. And I think that there are some really good case managers that go by that title, community support workers, in systems that have a recovery-oriented mental health kind of system. They're pretty good at that. So I think this is what I would say to ombudsmen. I think it's like I was saying, like in one of my early questions. The autonomy value that we all hold so dear is a very important value. It's about the right to choose. But if, in fact, we let it go there, then it can become kind of hollow if it's not autonomy in action. In other words, just protecting the person's right to choose, if there's nothing for them to choose, doesn't do very much. So I'm beginning to open my own thinking about autonomy to say, okay, I respect that right. So if somebody says, I don't want anybody coming in, I'd say, will you go this far with me? Will you at least meet somebody? You don't have to accept help. And then begin the process of time after time just coming in to have a relationship, and then see if the person still wants to reject it. But I think that if mental health types don't try, and if we don't look for autonomy in action as opposed to static autonomy, then I think we also will be letting people down a little bit. So I hope that they do find some resources for your resident, and by that I mean somebody who can get to know them, somebody that can that's willing to take the 3 months or whatever to get the person to be willing to go out for a coffee with them, and maybe that'll release some of the tension.
Great. Thank you so much.
You're welcome. Good luck.
Thank you. Ladies and gentlemen, as a reminder, if you have a question, please press the 1 followed by the 4. And the following question comes from the line of Sandra Hamilton. Please proceed with your question.
Thank you. Doctor, we have, it seems like, over and over again, where elderly, frail residents with dementia have some kind of a behavior, and the first thing the nursing home wants to do is send them to the hospital for a psych evaluation. Mm-hmm. And, they become more confused, they become more agitated. And do you feel that there is a better way to handle that?
Oh, Sandra, I sure do. In fact, I even know how to do it now. How do we get other people? How do we get other people to know what we do? What you describe happens all over the country and in varying degrees by different facilities at different times. And, one of the evolutions in the field that I have real concerns about is the notion of making specialty units for behavior residents. So if you're just old and just have dementia but you don't bother anybody, you can stay in just a regular home. But if you express yourself behaviorally, you have to go elsewhere. The psych eval or
even the dementia units that say they're dementia units will want people to leave.
Yeah,
if they have any kind of a dementia-related behavior.
Yeah, it's extraordinary. I I don't know if we've ever met at any trainings before, but I have for a number of years been taking an approach with dementia, which I kind of referenced in my previous question, which is this notion that all behavior is communication.
Yes.
And all behavior is a communication of an unmet need. And so the goal is never to get up. But like the whole transfer to the psych ward is to evaluate them and get them to stop this behavior. So I really think it starts with trying to find the opening in the facility's headset. It's like any little crack in the door in which you can say, you know what, we used to think that was a good approach. Mm-hmm. Now, some of them never did, but I always like to give people a little bit of face-saving room.
Right, right.
Yeah, I understand why you'd want to sit in for a second, but we used to think that was helpful. Now we know better. Now we know, in fact, that the environment, staff behavior, and unmet need are really what drives these behaviors. So before we try to get it stopped, our job is to figure out what the person is trying to tell us. An earlier variation on this theme was what was precipitating the behavior, but it still was like it's the resident's problem, what precipitated it them. And so I think one thing is to look for the opening in the conversation that says, we now have data, we now have evidence-based interventions, we now have ways to treat people with dementia, with behavior problems, as expressions of unmet need, and to treat them or to understand it and manage. It's not a treatment, but to understand it and to use non-pharmacologic interventions for people. These are not just symptoms of illness. When you can start that conversation, then you have a little bit of hope that you can make a bigger systems kind of impact. Homes that are beginning to embrace culture change, homes that use strategies even without full culture change, like consistent assignment, or homes that want to specialize in dementia, are beginning, I think, to appreciate this a little bit. Now, when it comes down to the individual resident, sometimes I think it's a matter of, and this is where I think you guys can have an impact, of saying, you know what, let's see if you're right. You already sent them, or you're about to send them. Let's actually do this fairly and do it by data and not just by perception. Let's actually look at whatever the disruptive behavior is and count it. Count it on 3 shifts for 2 weeks, and let's really study the pattern. And then if we haven't learned anything and there needs to be something else, and the person goes to the hospital, when they come back, let's be honest again. Let's look for another 2 weeks at behaviors and try to make some like individualized care plan that says, okay, before they were screaming and now they're somnolent and comatose, what represents quality of life? Now they're falling, or whatever. And, you know, at the individual level, I don't know at this point a better way than data to kind of force nursing homes to look at how that intervention just doesn't help, and we all see this, you know, time and time again. So to take the facility's point of view, I always try to find that, you know, their point of view. I'm sure you hear it like I do. Here's how it goes down. I'm trying to understand what unmet need it is, but they're keeping all the other residents up at night. If all the other residents are up at night, then my census is going to go down. I'm not going to make any money.
Right.
Okay, well, let's figure out, is there another way to deal with the noise issue? Always trying to see it from both points of view, even though ultimately we're advocating for the residents. Sometimes we can be most effective if we stand in the shoes of the facility for a minute and say, what really bugs them so much about this? And it turns out they're making the place look bad. So maybe we can solve that differently, you know. it's really not about that resident. It's about something else. And
or if they hit somebody, it's the other resident's family member that says they got to get out of here. You know, they got to send them out of here. You know, they react that way too.
Yes.
So.
True enough.
Mm-hmm.
True enough. Sandra, you know, one thing, and I don't know, Sarah, in the materials that are available at the NORC Center, if any of the stuff that we've done elsewhere on challenging behaviors in dementia. I don't know if they're available at the NORC website, but they are available at my website. And, you know, I don't know that they work that well, frankly, for like standalone, but you're obviously welcome to them. For those of you who are advocating in facilities where you do have the people that Sandra was talking about, elderly, frail, dementia, and behaviors, being perhaps prematurely sent to hospital. I have a lot of resources on my website under the sort of category of the challenge of challenging behaviors. And, you know, you're welcome to them if it will help, you know, crack into that conversation.
Okay. Thank you very much.
Yeah, good luck. Thanks for your question.
Thanks.
Thank you. Ladies and gentlemen, as a reminder, if you have a question, please press the 1 followed by the 4. And we do have a follow-up question coming from the line of Elizabeth Yeh. Please proceed with the question.
Hi. What's your website?
My website is www.susanwearymd.com.
This is Sarah, and we do have your website on some of the materials that we have on the NORC site as well.
Great.
Mm-hmm.
Thank you.
Hey,
you're welcome.
Do we have another question?
We have no more questions at this time.
Well, I have a question then. Susan, you've suggested many times that we, in the resident advocacy arena, get in touch with recovery resources and organizations and begin to see what we might learn from them and how we could connect them to some facilities or residents. And I was wondering if you could say just a little bit more about that. I know we're getting close to the time when Melissa needs to summarize the call, but if you could give us a few more specifics about where that movement's heading and a couple of tips about how Ombudsman might really be able to find those groups or that organization very advantageous.
Thank you, Sarah, for asking for more about recovery, because it reminds me that I wanted to tell you guys about a great success story, not my success, but the success of some folks in Massachusetts in a nursing home who had a facility with a lot of relatively younger residents, many with psychiatric disabilities. It was kind of their special niche, but weren't necessarily able to help people make a lot of progress. So they were just kind of living there and feeling kind of bored. And they decided to take a recovery-based approach, which basically, let me just say my word about recovery is this. Recovery is a way of living to make the most out of life. It's a way of living with hope. It's a way of helping people with mental illness begin to trust their own thoughts again. It's a way of empowering them. And the recovery movement largely draws on peer support. So it becomes a matter of peer-to-peer interactions. Now, folks from the great state of Louisiana looked at a project a couple of years ago with Mary Ellen Copeland, C-O-P-E-L-A-N-D, who is one of the leaders in this field. She has a website, and she has a whole training institute for training people how to go in and approach people with a mental illness to live their lives with hope. Many people who have come out of institutions, frankly, don't even know how to begin embracing recovery themselves. So this facility in Massachusetts decided to take on a recovery model in a facility that had a lot of dings and a lot of tags and a lot of surveyor deficits because of resident-to-resident assaults and resident-on-staff assaults and so forth. You know the drill. Within a year's time, not only did they come down to like one deficiency, but 6 or 8 of their residents with psychiatric disabilities recently were featured speakers in Worcester, Massachusetts at the recovery dinner, the sort of peer-sponsored program held at the library every year. And these folks from the long-term care facility went over and spoke, and it's hugely moving. I've seen a little video, and I'm trying to get the folks in Massachusetts to make it more widespread, but I've always believed it. They have the first sort of in-nursing home success story. So what they did was contact, I don't know if they went online or if they went to the Boston Psychiatric Rehabilitation Center. That's one of them. Again, I think this is on my recovery packet from last year's program on bad reps and bum raps or something like that. But Boston Psychiatric Rehabilitation Center is like a clearinghouse. You can also go to mentalhealthrecovery.org. That's a clearinghouse. And the first step is to find the partners in your community. Ask if you can just sit down and talk with them. Ask if they've ever thought about coming into nursing homes. Do they have any trained peers to come in to talk with other people about the recovery movement? And then what I would say that was really effective in Massachusetts, you get one person in the facility who becomes a champion for this and begins to open the dialogue in the facility to look at the different ways you do programming that actually is designed towards a more hopeful future and not just kind of being stuck here. Having that on-site advocate, the person who's excited about it, was, I think, a key ingredient in the Massachusetts success. But I think, and I really appreciate Louisiana really kind of stepping to the plate on this. I think I really applaud Massachusetts for doing the same. I think the recovery movement in long-term care is a natural partner with culture change, and it's going to be what I start really looking more and more at as ways to deal with these issues for mental health advocacy that we've all been grappling with for years. Thanks for that opportunity, Sarah.
Okay. We would like to thank Dr. Weary for sharing her time, talent, and expertise with us today. This has been just a wonderful call and so beneficial to us. We're going to be sending out an evaluation form. You'll get it here in a few minutes, and you'll find attached to it the mental health reference guide that the center is just releasing today. The call today was recorded and will be available on the center website, which is www.ltcombudsman.org. You can also find Dr. Weary's presentation from September 8th of last year on our website and other resources. So thank you all again for participating and for your wonderful questions, and thanks to Dr. Weary for sharing her time with us.
My pleasure. Thank you, Melissa, for bringing us all back together, and you too, Sarah.
Thanks to you.
Thank you.
Have a wonderful day.
Ladies and gentlemen, that does conclude our call for today. We thank you for your participation and ask that you please disconnect your lines.